Hey everyone, welcome back to the Gastro Girl Podcast. I'm your host, Jacqueline Gaulin. For many people living with inflammatory bowel disease, one of the most confusing things can be this. Sometimes you feel better, but your disease may still be active beneath the surface. Today, we're talking about the important difference between symptom relief and true healing, and why understanding that difference matters when it comes to protecting your long-term health. Joining me is Dr. Jessica Allegretti, a leading expert in IBD and someone deeply committed to helping patients better understand their condition and feel empowered in their care. In the first part of our conversation, we'll explore what's actually happening inside the body with IBD, why symptoms and inflammation don't always match, and how patients can better understand the gut-immune connection behind the disease. This episode is brought to you by Merck. Dr. Allegretti, thank you so much for joining me today. So great to have you on the show.
Thanks for having me. I'm really excited to be here.
So we're going to just dive right in. First of all, what is IBD and what actually is happening inside the body when someone has IBD?
Yeah, thanks for this question. I would say it's a layered question. So I will do my best to try to break this down. So when we talk about the inflammatory bowel diseases, we're not just talking about one thing. Generally, there are two major categories that we discuss: ulcerative colitis, which is inflammation that just involves the colon, and Crohn's disease, which can involve any part of the GI tract. I always say mouth to anus. It can affect any part, and that is a full thickness disorder, meaning the whole lining of the intestine can be involved. And so when we actually look in, there is overt evidence of inflammation. We see redness, we see ulcers, the bowel itself looks irritated. And this is often how we distinguish these inflammatory bowel diseases from irritable bowel syndrome, which often gets confused with IBD by many patients because they sound very similar, which is a functional disorder, meaning when you look in, actually everything looks pretty normal. What's happening is the nerves of the GI tract are not functioning correctly. So this is an overt inflammatory condition. And so what's happening and why this does happen is multifactorial, right? It's not just one thing that causes IBD. Otherwise, we would have found a cure already. It's very complicated. We call it the perfect storm hypothesis, right? You have to have been exposed to certain things, in the environment, some in utero or early in life. You have to have an altered intestinal microbiome. You have to have the right genetics. You have to be genetically predisposed. And all of these things have to come together. And this is what brings out this disease. And we often see this coming out for most patients, usually in the 20 to 40 age range.
So it's more than just digestive symptoms.
Absolutely. So when patients have inflammatory bowel disease, I always tell my patients, this is a whole body, whole person disease, right? It's not just how many bowel movements you're having or is there blood in the stool. Of course, we ask those questions, but often this can lead to significant fatigue, just generally unfeeling well, inability to eat, weight loss. There's a lot of concurrent anxiety and depression that can come along with these diseases. And we also know that these diseases extend beyond the gut. So there are a lot of what are called extraintestinal manifestations, so outside of the intestine. So patients can have joint pain, they can have sores in their mouth, they can have eye symptoms, rashes. And so again, these can be whole body disorders. And when we treat them, we're treating everything, not just the GI symptoms.
You did a really great job of explaining that. I've never really heard it explained to that in-depthness. And it's, is that a word?
I love it.
But no, I think it's a really great way to think about it, which leads me to my next question. Why do so many patients think of IBD just in terms of symptoms? There's other things going on, what you're talking about, that they can't see.
I think it's a good question. And I think too, when you're living with this disease day in and day out, I think the symptoms, sort of drive everything, right? It's like if you feel like you can't leave your house because you're having so many bowel movements or the urgency or your rectal bleeding, I think often that's where the focus ends up being concentrated on, right? And I get that. If I was, feeling like I needed to wear a pad to be able to leave my house with confidence or having to pull over on the side of the road, which we know patients have to do, right? This can be really pervasive. And so when I'm having conversations with my patients, I always tell them how you feel and the symptoms are critically important, but there's so much else that we also need to make sure we're managing. And that's how your intestine looks, what these objective markers of inflammation also show. Because we now know, and there's a whole set of guidelines called the STRIDE guidelines that really focus on this, we have to treat beyond symptoms. We know that there's actually a fairly poor correlation between symptoms and objective measures of inflammation. So we need both. We need symptom resolution when we're treating this, but we also need to normalize objective measures of inflammation as well. And that can be stool tests, blood tests, endoscopy.
I really think this is an important point because what you're saying is that inflammation is often invisible. So
Yep.
there may be the outside symptoms, like you talked about bowel movements or urgency. But what about the inflammation that is not always visible? Can you just elaborate on that a little more?
Sure. Yeah. I think one of the analogies I like is sort of like the iceberg analogy, right? We only see what's at the top, but there's actually a lot going on under the surface that often, is hard to visualize. And so we know that, again, there are things going on beyond the gut, and trying to understand where and which parts of the body are being affected for many patients, and utilizing, now that we've got better technology and better testing, we are able to assess in many ways, either with, again, blood tests, stool tests. We now have a modality called intestinal ultrasound, where we can actually measure bowel wall thickness using an ultrasound probe, which is really exciting. Um, and really just trying to understand how best to treat the patient in front of you. Because I have patients who say they feel fine, things are actually improving. And when we actually look in, either overtly or microscopically, so when I take a biopsy and actually look under the microscope, we still see evidence of inflammation, trying to make sure that we're treating every aspect, not just to symptom resolution. Because if I just treat the patient to where they say they're feeling better, but I haven't healed that underlying inflammation, I haven't really done the patient any favors.
Yeah, and that leads me to my next question. Feeling better versus actual healing. Why can patients sometimes feel okay, even though the inflammation is still active?
Yeah, it's a really good question. And I would say every patient is different, and patients have different tolerances. And I think depending on their life experience and medical experience, right? I think patients experience pain in different ways or discomfort in different ways. And it's always amazing to me. I have some patients who do not require sedation for colonoscopies. They actually don't want it, and they tolerate it without issue. And I have other patients, if we even attempted that, would be on the ceiling, right? Because everyone's pain receptors, how the nerve stimuli is different. And especially if you have some of that functional or IBS overlap, which a lot of our patients have, patients are much more sensitive, even to just, gas pains, right? Can be really uncomfortable for a lot of patients. So it's hard to know why some are like that and others aren't. It probably, again, has a lot to do with your own genetics and environmental exposures, and, again, your own life experiences. But I think it's just an important recognition that everyone is different. And so just because the patient says they feel fine, and I think for me, I've known many of my patients for a decade plus at this point, I know whose symptoms are very reliable and whose symptoms aren't. And I think the patients know that too. I have many patients who they'll say, I feel fine. I'm like, yeah, but you always feel fine, right? Like, we actually now need to look and see what's going on. Whereas others, the second we know something starts to creep up, something real is happening. So it's also that patient doctor relationship, I think, helps me tease that out a bit.
And why, how to ask this question? We're always focused on the bowel aspects
Yeah.
of IBD, but can the symptoms, like say the bowel aspects are okay, but can inflammation be causing other things such as skin issues
Yeah.
or other things that are happening that, it's almost like silent.
Totally. So I mentioned those extraintestinal manifestations before. So we know that the gut inflammation, there is gut inflammation, and for many patients, a good percentage of patients, they will experience extraintestinal manifestations, and that's true for both Crohn's and ulcerative colitis. Now, some extraintestinal manifestations mirror gut inflammation. So if you have gut inflammation, these extraintestinal manifestations will come out. However, there are some extraintestinal manifestations that, even if luminally, so in the gut, you are in remission, the extraintestinal manifestations can still be present. And, that's particularly true for arthralgias, especially in the small joints and the fingers and in the wrists. Patients can be in remission from a luminal standpoint, but still have significant joint symptoms, or psoriasis, for example, that either may be concurrently related to the IBD or a secondary complication of one of the medications they're on. So we can see some of these other inflammatory complications, even if we've been able to get the luminal disease under control. And so sometimes we either have to try to treat those separately, or if they're really pervasive and disturbing quality of life, right? We may then have to alter the treatment plan to make sure we're tackling both things with one therapy option.
Yeah, so let's talk a little bit about treatment options. If a patient is diagnosed with IBD and there's multiple things that are happening because of this inflammation that a lot of times might not get talked about all the time. When I talk to some patients or people that either just got diagnosed, inflammation they don't really understand fully what is happening in their body. And I think that's an important point to understand, because then it will probably make more sense when the doctor, someone like you, is prescribing treatments. So how do those conversations work, and what would you tell someone about the treatment options and how they address what's going on?
Absolutely. And these are conversations that I have almost every day in my clinic, right? I think whenever I'm seeing a patient for the first time, um, regardless of where they are in their treatment journey or disease journey, I always like to take a step back and say, let's make sure that we're speaking the same language. Do a little IBD 101, make sure that patients are educated about their own disease, where their disease is, what disease they have. I think I often encounter patients who don't know the difference between Crohn's and ulcerative colitis, or think that you can have both, right? So I try to dispel some of the things that they have maybe heard or read, and try to just make sure that we're speaking the same language going forward, because I think it just makes the future conversations easier and more fruitful, right? So I always like to make sure that our patients are educated about where their disease is, what disease they have, and then we talk about therapies, right? Because I think the therapeutic options now, I always tell my patients, nobody wants to have IBD, but now is a great time to have it, because we have so many more treatment options with so many under development, compared to when I started practicing. And so we can really come up with a plan that's going to work best for the patient. And so we have basically the general category, two categories of medications are what we generally call conventional therapies, although I think that term is going out the window. And that refers to things like more traditional or old school immunosuppressants and mesalamine, and then the advanced therapies, which are biologics and small molecules. And I think there has been a previous hesitancy almost about escalating patients, both from providers and patients, so escalating patients to what we call advanced therapies, because they've been deemed sort of like serious or this big leap, probably because a lot of them are protein based, right? And so they have to be administered as IV infusions or sub-Q injections, because you can't swallow proteins, you'll digest them. So they have to be administered that way. But there is often this seriousness that becomes associated with that because of how they're administered. And I think many patients, I'll often say, I know I can see you're thinking about chemotherapy because of how these drugs are administered, but this is not that. And I think that many of our patients are undertreated. We know that when we've looked sort of broadly across the US, like only 5% of patients who are eligible for, say, biologic therapy are actually being prescribed them. So we can and should be doing a lot better. So I talk to patients about their disease, their extraintestinal manifestation profile, and then what we have that's currently FDA approved for their disease, and talk about which may be the best option based on their disease, their, again, extraintestinal manifestations, and their preferences, right? How do they want to receive the drug? What's going to be most convenient for them? Because ultimately, the best drug is one a patient's actually going to take. So this is how we start to have these conversations.
So why do you think biologics are under prescribed, or why patients don't understand? Do they know? Is there things that we can help educate here in this episode about what a biologic is and what they should be talking to their doctor about?
Absolutely. I think there's a lot of fear out there. I think, when we had sort of anti-TNFs, which were sort of the first biologics that we had on market, these are immunosuppressing drugs. They're great drugs, and I still use them readily, but they are immunosuppressing. And there has been some, although albeit still extremely rare, links to development of some cancers, right? So I think that is sort of a message, I think, that has permeated the landscape pretty pervasively. So often patients will come in really concerned around, um, you know, being very immunosuppressed and being very sick because of that, developing cancer, or being almost like, a bubble person, right? Like they can't do anything or live a normal
Right.
life because they're going to be so immunosuppressed. Or again, this sort of chemotherapy imagery that comes with biologics. They're going to lose their hair, they're going to feel unwell. And so I often, I always ask my patients, like, tell me what you're worried about. Tell me what you've read. Tell me what you've heard, because I think a lot of it, albeit well-meaning, right, is misinformation. And so trying to debunk some of that so patients have the correct information to make informed decisions about their treatment. And so what we currently have right now is a wide range of therapies that have different mechanisms of action. So they have different targets within the body. And many of our new agents are minimally immunosuppressing. Some of them are gut selective, and so they don't even work systemically. And we're not seeing increased risks of serious infections. We're not seeing cancer development. Many of these drugs are safe in pregnancy, for example, or even if you had an active cancer diagnosis. And so I think there are a lot of options that are very safe and very well tolerated. So I think, again, it's around dispelling some of those maybe outdated misconceptions about some of these meds. Because I
No,
want
when
patients to get the best therapies possible, right?
yeah.
I mean, that's what we want.
Yeah, and that's why we do this. We
Yeah.
want patients to be educated so they can take
Yeah,
this information and go back and have an intelligent conversation, an educated and informed conversation with their provider.
absolutely.
We're not saying, yeah, dude, rah, rah. We don't
Yeah.
know what their situation is and what their health situation is. So we never push anything, but we want to give information. So we really appreciate the insight here. And in the context of feeling better versus actually healing, you mentioned monitoring.
Yeah.
And how does that work? I think this is really important. You don't just hand a patient a prescription and say, see ya, and
Yeah.
a lot of time there's more of an update and a contact. And how does that work for patients?
Yeah, absolutely. So I always say this is sort of a staged approach, right? The first is the conversation around all of those things we just mentioned, their disease, their preferences, what's going to be the best therapeutic option for that patient. So first you have conversations and shared decision making around the therapy you've chosen, but that's not where the work ends, right? That's where the work just begins, because we have to make sure that we got it right. Because unfortunately, still in 2026, we don't have one test that says, I get an anti-TNF and you get a JAK inhibitor. We actually don't know which pathway is driving an individual's disease. And so we're making our best guess based on all of those things that I just described, but we have to make sure that we got it right. And so I always tell patients we're going to set uh, monitoring time points and markers in place so that we know that we got it right. And if we didn't, it gives us real-time opportunity to be able to pull up and ask why, because there's lots of reasons why someone might not be responding to therapy. And so a little of this will be dependent on which therapy you've started. But for the most part, like how this might look in a practice is we get baseline assessment. So if you're wondering why you have to do all this testing at the beginning, is because we need to know what's abnormal to be able to know what to follow. Because if you don't mount a fecal calprotectin or a CRP, for example, that's not a helpful tool, and we're not going to keep testing it. So getting everything up front, and then we start someone on therapy, and then I'll say, in 4 weeks, my amazing nurse Beth is going to call you. We're going to check in, see how you're doing symptom-wise, right? Make sure that those symptoms are improving. 4 weeks after that, you might see my fabulous PA Sarah in clinic. She's going to get some blood work. We're going to see what's going on, see your CRPs coming down. 4 weeks after that, you're going to see me in clinic. We're going to check that fecal calprotectin, make sure it's coming down. And ultimately, at the end of this, once we've started a therapy, we do need to do that endoscopic assessment to confirm that the tissue has healed. But I always tell my patients I want to be 99% sure what I'm going to find at that endoscopic assessment, because I've been monitoring you so closely throughout. Because at any point, if the CRP is not normalizing, if you're not feeling better, if the fecal calprotectin isn't coming down, we pull up and ask what's going on. Are you underdosed? Are you taking drug? Have you developed antibodies? Do you have a new infection? There's a whole host of reasons why somebody might not be responding, and that gives us an opportunity to figure it out.
So it sounds like they could be feeling better, but there's not the healing that you had anticipated and that's why you want to do further testing with an endoscopy or
Well, it's
that's
more about, again, that symptom. So we
yeah,
still pay attention to symptoms using what
right.
are called patient-reported outcomes, right? Abdominal pain, stool frequency, rectal bleeding. But we also absolutely must be checking those objective measures of inflammation too, because somebody could be feeling better, but we haven't actually healed their bowel yet.
So that's really important. And there's no, with all of these wonderful treatment options out there, there's no way to decide objectively what would work. There's no test that would kind of predict that this treatment plan would
Not
work
yet.
better. Not yet.
Yeah.
It's
Hopefully
not
soon, but not
targeted.
yet. Yeah, not yet. Not yet.
Well, thank you so much for joining us for this episode of the Gastro Girl Podcast. And we want to especially thank you, Dr. Jessica Allegretti, for helping us better understand the important difference between feeling better and truly healing in IBD. And don't forget to like, subscribe, and share this episode, as well as the Gastro Girl Podcast channel, with anyone who you may think may benefit from the education from the experts. Thank you so much.
Thank you for listening to the Gastro Girl Podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl Podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.